So I'll put up in the slide. So very good morning to one and all. And today's class is all about giving the preparation of the mouth for the removal partial dentures and all. It's basically pre-prosthetic surgeries in the prosthodontics in the concise version of the class. So objective of this lecture would be giving the pre-prosthetic surgery in the giving a knowledge you all on the pre-prosthetic surgery in the theoretical aspect as well as the practical aspect and all. And the contents of this class would be giving an introduction and when we are supposed to intervene the oral surgical preparation, what are the pre-prosthetic surgeries in preparation, and what are the abutment preparation of the teeth and all. So giving you the introduction, the success of the failure of the removed partial denture is dependent on many factors and all. Suppose if the foundation is great, we can build a Taj Mahal. Suppose the foundation is bad, even if you make a Burj Khalifa or something, it can be trembled in in a span of seconds and all. So if the foundation is great, then the processor will be great and all. For example, the teeth, if suppose the patient has a carious teeth and all, despite you aware that that's a carious teeth and it can be able to take the load and all, still you go ahead with the process and all, patient will always give a complaint right after the process delivery and all. So our duty is to correct those things and all. The pre-prosthetic surgery is all about giving the best foundation for the patient and all. To achieve the success, the practitioner must develop the sequence of the sound treatment plan based on the clinical radiographic evidence. As you all know that when the patient comes for the processes, we all know that prior impression is there, secondary is the jaw relation, teeth arrangement, and the insertion stage and all. But we are not talking about these 5 stages. We are talking about the what are the prior to that thing. Suppose the patient has the hopeless teeth is there, it has to be extracted, suture it, wait for the healing, then wait for the any kind of a bony growth is there, that has to be corrected. Then only we can plan for the primary, secondary. That's well. Okay. These findings must be carefully considered in processes, design, and mouth preparation. So the first one is the oral surgical preparation, relief of pain and infection. There are classical couple of examples, and I can tell you this is mainly of the practical scenario. For example, suppose the patient has a hopeless teeth is there. As I told you, it has to be extracted out, wait for the healing. Then if any, see whether any kind of a bony projections or bony sharp nodules are there, or any kind of a exostosis or torre is there, it has to be corrected out. Make sure that area is very healthy in nature, then only we can go ahead with the primary android. That is the first one. Suppose the patient has a bony prominence is there, then or a sharp spicule is there. This spicule has to be cut it off. Then we can plan for the suturing. Then wait for the healing. Right after that, then we can plan for the processes portion. Next one would be imagine patient has the both the side, right side and left side. Patient has the undercuts. In that scenario, you see which has the most undercut is there. Suppose here we have on the right side and left side. The right side it has the 6 mm of undercut, and the left side it has the 4 mm of undercut under. The least one it has to be corrected out. Okay, only the one undercut, the unilateral undercut is go ahead. Bilateral undercut, we are supposed to go for the intervene the surgical thing and all. So which is the least one is that correct that thing, then you can plan for the process and or the next one would be the any kind of a torre is there. Suppose if it is a little manageable thing and all, we can plan for the same a process and all. We don't need to go for the surgical intervention and all. So these are the main things and all. So usually the surgical preparation when you're planning the thing and all, you need to palpate with the hand with the finger while then all around the ridge area and all. See whether the patient has the pain and all. Normally, if the healing is satisfactory, if it is an uneven full extraction and all, patient never give a kind of a pain and all. Suppose that when you by palpating, patient has a pain and all, it has to go for the surgical intervention and all. The next one is a prosthetic mouth preparation. This is the main content of the thing. Still, I will concise the topics within the 5 headings and it's under 6 headings. It is basically 5 are there. The fifth one subclass headings are the last 2 are. The first one is the correction of the occlusal plane, correction of the malalignment, provision of support of the weakened teeth, reshaping the teeth. Occlusal rest, last two are the receipt preparation for the anterior as well as the posterior. First one would be the correction of the occlusal plane angle. So the correction of the occlusal plane, it is like we can classify into two types. That is, one is in the CD as well as one is in the RPD. So basically, this topic is for the CD. So we'll jump into the CD top. Sorry, the RPD. So we'll jump into the RPD. Most of the RPD patients, the extraction won't be a sequel in nature, in the sense they will extract it whenever they feel like. If the teeth is mobile in the anterior, they'll extract the mobile anterior, and they felt that they have a pain in the posterior, they'll go for the posterior. So it's like it doesn't follow the sequence and also what happens it is the opposing teeth can be tempted to rise above. It means suppose the upper teeth is like this way and the lower teeth is like this. Usually it should be in a go in a smoother planar in a same plane. Suppose if the tooth has been extracted out, the lower teeth tend to go above. Vice versa also. Suppose that upper teeth is there, the lower teeth, if we extract it prior, the upper teeth can tend to go downwards and all. So in that scenario, our duty is need to correct the plane. What you have to see is see the other two teeth, adjacent teeth, same manner you have to planar reduction had happened. Suppose if it is a the opposite teeth, it is 1 mm above from the adjacent teeth, and then we can plan for enameloplasty. Then we can correct the thing. Suppose it is too much of higher, then we can plan for the intentional RC, then giving a crown and correct the correct the planar thing. And suppose the teeth is measly drifted thing and all. In the first we had to do is we had to ask for the orthodontical opinion. See whether it can be corrected by the orthodontically. Yeah, suppose if they can correct the orthodontically, well, good enough, we can plan for the next stage would be the primary impression and all. Suppose if the orthodontically cannot be done, then we can plan for the intentional RC root canal over there, then followed by a crown. So correcting the planar is mandatory in here and all. So basically what we are planning here is correcting the planar either by enameloplasty or giving the intentional RC followed by a giving a crown, or intentional RC followed by a crown, or if the suppose nothing is working out, we can plan for the extraction of the teeth, because it's saving we won't be it won't be more productive in the way and all. It will be even if you're correcting the abutment teeth, it may cause the too much of bone loss and all. So we can better plan for the extraction if nothing works out. So we'll read out. The occlusal pain is most partially heterogeneous mouth will be uneven. The severity of the unevenness will determine the treatment need to be correct the condition. The tipped molars present the significant problems, remove partial denture therapy. The ideal solution is upright the teeth orthodontically. So first option would be orthodontical correction. If the discrepancy is minor, the occlusal pain is corrected via enameloplasty. Suppose a little bit of 1 mm thing and all, we can plan for enameloplasty. If the migration and tipping is more severe, the only we can plan for a crown. If when you're reducing the down, the patient sense that too much of pain in the scenario, if too much of pain and all, then we can plan for intentional root canal followed by crown over there. If nothing works out, extract it out. So coming to the next one would be the correction of the malalignment. So malalignment sense, the teeth, it can be placed on the either too much of labally or too much of lingually. And in that scenario, what we can do is correcting the orthodontically possible and or not. The thing is, we can plan for the enameloplasty, or we can plan for the on-leg crowns and all. If nothing works out, then try to correct it within the process and all. But even if you're correcting the little bit of a processing, there are chances of getting the failure of process and all. But try to correct it within this enameloplasty or orthodontical correction, enameloplasty or on-leg crowns and all. Then coming to the provision of the support for the weakened teeth and also there are chances of the teeth the patient have there will be a multiple carious teeth and all. So whenever you see too much of carious teeth and all, it has to be corrected by the conservative manner, where in that conservative manner you have to restore all the teeth and all, and you still think that right after the restoration the teeth is not good into the sound tooth form and all, you can plan for a crown and all. Even if you give the individual crown of each teeth and all, you still think that it's not giving the too much of support to the teeth and all, you can plan for the splinted crowns and all. So when you're giving the splinted crowns to the teeth on the area, you are not only giving the too much of support to the area and you're giving the best processes for the upcoming processes. So you'll get the more support of the area of the anatomical areas of the teeth. Coming to the next one, that would be the enameloplasty that we are already discussed. Suppose the teeth, which is little bit either teeth can be moved either upsidewards or or the migrated towards the mesial or distal end. So if it is within the limits of 1 mm and 1 millimeter and we can correct this thing via using the enameloplasty. So when you're doing the correction within the enamel level and so right after the enameloplasty, the only thing what you have to do is need to polish around that area. Otherwise, there is a lot of plaque accumulation followed by there is a caries can happen and all. Okay. Then next one is the enhancing retentive undercuts and all. So what do you mean the suggestive of the and all? When you're giving the process to the patient and all, suppose the patient doesn't have the this thing, the retentive component, like a little bit of a mesial migration, distal migration, if not their thing and all, our duty is to create this one artificially. So we are, suppose the teeth is like upright, straight and all, you are still think that when you give a class, it's not helping for your retention and all, you're giving some kind of a little bit of a undercut, which is artificial in nature, so the class can engage. So that's how we can enhance the retention quality and all. The next one is giving the receipt. That is for the anterior as well as the posterior. For the posterior, it is easy to tell it's in the triangular in shape when you're looking from the occlusal aspect. Okay. And when you're looking from the side view, it has to be less than 90 degrees. Okay. And it should be in the spoon shaped manner. And the deepest one, it should be coming into the central of the fossa. And it comes within the 1 mm and the burr we are using for this thing and round burrs. Coming to the and this one, this receipt for the posterior, we are planning, we can give not only on the teeth, okay, we can plan to give for the amalgam restorations and all. Here also we are using the same burrs and all. And suppose the patient has undergone the root canal of the respective teeth and all, we can plan for a crown. In that crown, we can plan for the receipt area and all. So we can plan for the making impression, we can get a receipt, we can accommodate over that area. When you're planning for the receipt for the anterior and in that case, we can plan for the cinculum area. It is inverted V shape. Okay. It's an inverted V shape, inverted C shape. Sorry, it's a C shape. When you view from the side view, you can able to see there's a V cut kind of thing. And also, when you view from the side, it should be in inverted V. When you're looking from the lingual side, it should be inverted C shape. So these are the main pre-prosthetic surgery in a consistent manner. Thank you.